Hello, welcome to another episode of the Project Purple podcast. I'm Dina Verley, founder and CEO of Project Purple and the host of the Project Purple podcast. We have another interview for you coming up with a very special guest after a few quick updates. The Project Purple podcast has surpassed over 100,000 downloads. So excited. When we started this podcast over 6 years ago, we didn't have a number in mind. And now that we've surpassed 100,000, it's just really, really special. So we want to thank all of our guests for allowing us to share their journeys and all of you for listening to what we've been putting out. So thank you so much for making the Project Purple podcast the success that it has become. 2023 was a record year for us, and already we are almost a quarter through, or through the first quarter, I should say, 2024, and we are already on pace for another record year. And I just want to say thank you to everyone who made 2023 so special for us, the supporters, the people who donated, or those that participated in a Project Purple event. Speaking of 2024, we've already launched many of our 2024 run teams. And exciting news, we're back in the Boston Marathon as an official charity partner. This now makes us the official charity partner of the 5 largest world marathons. Many of our other 2024 races will be launching very soon, like the New York City Marathon, hint, hint. Our virtual event series is back here in March. We are back with our Purple Patties virtual event for the 3rd straight year. For those local to the Connecticut area, our 4th annual charity golf classic is happening on Monday, June 3rd. We're excited to bring that back for its 4th year. To learn more about all these great events, visit our website at projectpurple.org and make sure to follow us on social media to stay up to date on all things Project Purple. Without further ado, let's meet our special guest coming to us from sunny and beautiful San Diego, Dr. Ezra Cohen, MD, Chief Medical Officer of Oncology at Tempus AI. Ezra, thank you for joining us here on the Project Purple podcast.
Thanks, Dina. My pleasure. Thanks for having me.
So before I hand the mic over to you, I just want to read your bio here. We're excited to have you on here. As I mentioned before we hit record, we do bring specialists from the cancer space on often, not necessarily focused just in pancreatic cancer, but I know the folks from Tempus, we've been talking to you guys for a while now about bringing someone on to talk, and I'm excited to have someone at your level here and your expertise on the podcast. Before you got to Tempus AI, you were recently the chief of division of say this 10 times in a row, division of hematology. There we go. Hematology, oncology, as well as the associate director of clinical science at UC San Diego, UCSD, Moores Cancer Center. Dr. Cohen also led the Precision Immunotherapy Clinic and co-directed the San Diego Center for Precision Immunotherapy at UCSD. Before UCSD, Dr. Cohen spent 15 years at the University of Chicago, where he was the co-director of the Head and Neck Cancer Center, as well as the Hematology Oncology Fellowship Program Director. Thank you for joining us here at the Project Purple podcast.
Yeah, again, thank you. And yeah, happy to talk about what's going on, both in research and certainly in Tempus.
Now, I know we were talking, as we said before, you're based in San Diego. You were in Chicago for 15 years, almost a lifer. I guess we could say I wouldn't say lifer, but for a very long period of time. Let me put you on the spot here. What's the biggest thing that you miss about Chicago? And what's the thing that you don't miss about Chicago?
Chicago is a wonderful city. There's so many things truly I do miss about it. I think that the best thing about Chicago, and I like cities, I like living in a city, is everything's doable. There's great culture, there's great museums, theater, restaurants, in the summertime, the outdoor events. And I did live in New York for some time, and no knock on New York, but for New York, things are a little bit harder to access, both in terms of logistically getting to the event and, of course, paying for whatever it is. And Chicago just it's much easier to do stuff, especially for a city its size. So really, really miss that. Don't miss March when it's still cold, it's still gray, and you're just wondering, when is this winter going to be over? But you
Yeah.
know what? That first spring day comes, and all of a sudden your attitude completely changes, and you
Yeah.
forget about the last 6 months, and you're
Yeah.
enjoying enjoying the city again.
I love Chicago. I know we were talking about this before. Chicago is probably one of my favorite big cities to go to, and you nailed it right there, right? Like it's very accessible, but the weather is just like, I've been there. I remember I was there in like 2018, and it was like 30 below or 40 below,
Yeah.
and living in Connecticut, like it gets cold, but it's not that cold. And I remember just being there. And I think I had to buy like a scarf because I had a hat, but your face is still exposed. And, Chicagoans know, like, you got to like dress appropriately. I think that's the key to getting through it. But yeah, the
It can
winters
be
are
brutal.
brutal, absolutely brutal. Well, thank you for sharing those two tidbits there on Chicago. Let's talk a little bit about what you're doing now at Tempus AI and talk a little bit about maybe a little bit about your background, and then we'll get into some questions about what you guys are doing.
Yeah, great. Really, my background and honestly, the reason I even went into oncology in the first place ties in so well with what we're doing now at Tempus and the reason I went to Tempus. If you'll allow me, let me go back a couple of decades. And really, the reason I got into oncology was from doing palliative care as a family physician. I trained to be a family physician, and my dream in medical school was to go to a small town and do everything and do deliver babies, do minor surgeries, work in the emergency room. And I did all that. And as part of my practice, I was also doing palliative care and home hospice. And it was during the home hospice experience that I really began asking sort of those critical questions, the why questions of why did this person get this disease at this time, and why didn't their treatments work? As you can imagine, hospice, all of our patients were unfortunately close to death. 95% of our patients were cancer patients. And I really began to get interested in oncology and its biology and the mechanisms and realized that, boy, we were so unadvanced. We were just so unsophisticated when it came to um, cancer, what we knew and how we treated it. Now, this is going back more than 2 decades. Actually, I dare say almost 3 decades. So I'm aging myself, and I don't mean to be pejorative in all the work that had been done to get to that point. It was, you have to understand, this was before sequencing. This was before the appreciation of the human genome. We were doing, as a research community, the best that we could back at that time. This was, I'm talking about the early 90s. And to think back about how far we've come is just really extraordinary in that time period. But personally, I thought this is what I wanted to do. I became a physician to help people, and oncology just seemed to me like the greatest need at the time in medicine. And so I retrained. I went back and did internal medicine, and then did my oncology fellowship at the University of Chicago, as you mentioned, and then stayed there for the next 15 years. And throughout that time, I always felt like the key to treating a cancer patient was finding out exactly what made their cancer function and grow. Because if we think about it, cancer is really it's a chaotic world with the alterations and mutations that are present, the metabolic needs for growth, and to keep up with all the um, uh, debris, really, that a cancer cell uh, creates, and at the same time, the growth demands on a cancer. A cancer has to function in specific ways, and if we can decipher that, in addition to figuring out how the host is responding to the cancer, then I truly believed we could find a solution for every patient with malignancy, with a cancer diagnosis. And then, as I began to first use Tempus, and of course, Tempus was started in Chicago.
Mm.
I knew some of the people that started it. I knew the first chief scientific officer very well. He had a laboratory just a couple of floors above mine at University of Chicago. And as Tempus evolved, I realized that Tempus was doing what I wanted to do on a grand scale, on a population scale, with this mission of finding the right treatment for the right patient at the right time. And that's really what we do. We create tools for providers and for life science companies who are developing drugs and other products, to make those perfect matches so that cancer doesn't have to be, that devastating diagnosis or that frightening word that people hear and it stops them in their tracks. It shouldn't be. And I truly believe that our generation has the mandate to make that difference.
It's so fascinating, and like everything you said, like I'm nodding, for the, I don't know if our audience will see me, but I'm nodding here, and it's just so wild. I mean, first of all, thank you for doing this, and for going down that path, because you probably could have been it sounded like, you were very successful in that one space, and then you decide to shift. And I'm always kind of curious, was that shift, and this is first question here, just talking about your background, do you ever look back, like hindsight's always 2020, but was there a patient or was there a time when you just said, hey, I've had enough. Like this is, we have the means, to your point, like we're in a place now where we have the ability to find better outcomes for this. So was there a person or a case that was like,
yeah, there was, and there have been several along the way, but the one patient that triggered it all for me was a woman I was seeing in hospice, and this was home hospice. So we would actually go to the person's home and look at their environment, try to put things into the house that improve the quality of life as much as possible. This was a woman, she's 33 years old, okay, dying of ovarian cancer. She had exhausted all therapies, all available therapies at the time, and she had 4 children. And you go to the house, and her whole family's there. The kids, and I think the youngest was, I think about 4 years old, something like that. A young child. Her husband's there, and that's when it really struck me. It really hit home, because here was a woman. I was at that age at the time. We were, almost the same age, and I just thought, this shouldn't happen. This is terrible. And I'm using colloquialisms to express a grave situation, because cancer shouldn't end the life of a 33-year-old woman of 4, woman with 4 children. Not only does it obviously affect the person who has the disease, but her 4 kids are going to grow up without a mother. Her husband is going to grow up without a wife, her parents, her brothers, sisters, the entire community. And it's just devastating. And that was the one patient where I really thought, I want to do more. I want to see patients in a different part of this process, not when they have just a few weeks to live, but when science and medicine can really do something to change the course of this person's life and this person's disease.
So powerful. So then why the move over to Tempus?
Yeah. And so I was in academic medicine for over 20 years, and had a independent laboratory. I was doing a lot of translational and clinical research. You mentioned the precision immunotherapy clinic, and was doing, academically was doing great, fully funded grants, successful career. And then Eric, Eric Lestovsky, the CEO of Tempus, approached me and said, because I'd been working with Tempus for a while, had even been consulting with them, and he said, "Hey, the chief medical officer role just opened up at Tempus. Would you be interested?" And at first I thought, well, it seems like a interesting job, but I'm doing pretty well and really have no reason to leave academics. I'm really enjoying what I'm doing. But then I started talking more and more with Eric, with other people at the company, and I realized that Tempus has gathered the greatest database for cancer in the world, and I don't say that lightly. That is the truth. It is now, it's about 100 and it's almost 200 petabytes of data. For listeners that know what TCGA is, you'll appreciate this. TCGA essentially was the effort by the NCI, terrific effort, to really begin to catalog molecularly every cancer that we have. And pancreatic cancer, of course, is one of the cohorts. So TCGA took about 500 cases from each cancer, and they fully sequenced them, and really began to answer critical questions about the biology of each cancer type. We have 200 times more data than TCGA. And with that level, with those, with that amount of data, you can begin to ask critical questions. And not only do we have these, the genomics and the transcriptomics of these, but we have information on T cell receptor, B cell receptor, on tumor microenvironment. And of course, we know what happened to these patients clinically. And so that's when, sort of the light bulb went off, and I thought, oh boy, like I can do things we can do things as a company that I never even dreamed of.
Yeah, and I think like so for the listeners at home, and I know this is like, and I'll stay in my lane in terms of pancreatic cancer. Like there's no roadmap. And my mom's a 2-time breast cancer survivor, and this is part of I'll share my family frustration here with cancer. And we've had many cancers in the family. We just have a high propensity, and we also have the BRCA gene to boot as well, right? So we've got that against us, but when we look at roadmaps, right, and there isn't a roadmap in pancreatic cancer, and I think that's one of the biggest frustrations, with the space is that, why does someone do very well on FOLFIRINOX, but then you have another patient that does really bad? And then, yesterday the news, the FDA just approved this new frontline medication. It's giving people 2 more months, which is a big victory in the pancreatic cancer space. But this roadmap, which like you look at breast cancer, like my mom, she had it in 2001 and then in 2016, and the roadmap was there. They told her what to do, what types of treatments, what to expect, what outcomes. And breast cancer is still a very bad, all cancers are bad, right? But I think, again, to stay in my lane, this roadmap and to have this amount of data is really critical, right? Like it's the end all be all of how we can crack this thing for all diseases.
Absolutely. The last statement you made is absolutely true. So what we realize now, and we use the term AI now very, very loosely. I think every company now is an AI company, one way or another. In a sense, we have to be, but really, it's about what we can do with big data now that we have the ability, to collect and store it. So that's really only over the last decade. But B, to use language learning models, computational tools to integrate and begin to really interrogate large data. Now we have the tools to be able to ask those critical questions. Simply, so we had to get to this point, right? You go back 15 years. We couldn't sequence a genome efficiently. Okay. So we didn't even know what made, cancer tick. We didn't even know the alterations. Then you go to now being able to, a point where you can routinely sequence a genome, but then you have to begin to understand what those genes mean. And then you get to things like transcriptome and proteomics and other tools to really understand the molecular phenotype of a cancer. And now you've got tons and tons of data. So what do you do with it? So all of these things had to develop. We needed time to develop the technologies to be able to begin to ask these questions. And there's more technology, of course, that's going to be developed, and it's going to come. But now we're at a point where we can begin to really address key questions. Let me circle back to pancreatic cancer in just a minute. The other thing that's happening before I do that is the pace of advancement is also accelerating. So we're not going at a linear pace where one advance is happening after another. We're actually making discoveries at an even faster rate, which is really exciting, which means, a decade when I first started in medicine isn't, what we did in a decade, we can do really 10 times as much right now in that same period of time, which is terrific. Pancreatic cancer is one of those cancers where there isn't as much low-hanging fruit, unfortunately, and one of the reasons. There are many reasons why pancreatic cancer is challenging, and you don't need me to tell you it's one of the most challenging, if not the most challenging cancer we face, pancreatic adenocarcinoma. But there isn't as much low-hanging fruit. So, and what I mean by that is we've sort of now gone past the era where we can find a molecular alteration, usually a mutation, and it's easily targetable. We're now at a point where we have found almost all of those. Not all of those. There's still some to be discovered, especially what we call fusion events that are a little bit harder to see, and some of them a little bit harder to target. But we're sort of now progressing beyond that, where it started with lung cancer and EGFR mutations, and we discovered that EGFR inhibitors worked exquisitely well, and then we went on to find the next one and the next one and the next one. Unfortunately, pancreatic cancer doesn't have a lot of those. A few patients with pancreatic cancer do have those. It's not a universal no, but the majority don't. And so now we have to go one level farther and ask, okay, with the genome that we have in front of us, how can we interpret these data to come up with the best treatment? And in fact, we do have, you mentioned FOLFIRINOX, and as you know, there are two major treatments for first-line pancreatic cancer. And we do have an algorithm that can help providers, we being Tempus, has an algorithm that can help providers decide, well, should I pick FOLFIRINOX or should I pick Abraxane as the first choice? And you don't need me to tell you, that first decision is a critical one for pancreatic cancer patients, because for most people, you don't have a ton of time. But those are the kind of things that now we can begin to do as we use the newer technologies to interrogate data. And then further than that, we can, of course, we're now in the age of immunotherapy for cancer, and we can begin to understand the tumor microenvironment, the host, how the cancer and the immune system interact. And although there have been greater strides made in other cancers, but we're beginning to think about pancreatic cancer as well as a valid target for immunotherapy, and beginning to make, small steps to start, but at least it's starting. And again, the technologies that are available allow us to begin to understand that at a much deeper level.
Yeah, I think something you just said is very powerful, and I caught it because I have my notes here, and I wrote something down before. And you said this a couple times here, Ezra, with this evolution of technology and advances and this roadmap. I use the term roadmap, right? And all this great work that you guys are doing at Tempus, because you have the data, right? There's this book, I forget the author here. If I look on the bookshelf, I think it's called The Death of Cancer. And it was a gentleman, he was at Yale for a while as an oncologist, and he talked about, this idea of cancer being eliminated, right? And, I think in today's society, like everyone, it's either white or, it's like either one side or the other side, right? There's no in between. And I think, segue, like, I think we've got to find a way to manage cancer. I always try to say, because I try to be a realist. Like, I don't think we're just going to get rid of cancers. But if we can find ways to manage it and, but my point here, and in this book, he talked about like leukemia. And 30 years ago, leukemia had like a survival rate of like, it was like 5%. It was like, it's awful, right? And they did all these treatments, and now leukemia has a very high success rate, right, given the protocol that they have. So do you think like we're at this like really interesting time, and you said like we're not making like these linear jumps, but we're making these massive jumps where we can take a decade's worth of work, and that decade's worth of work may happen in 6 months. And I'm just throwing that out there just as an example here. But like this is just a lifespan of like, let's say, pancreatic cancer and maybe some other really challenging cancers, because of technology, because of companies like Tempus out there doing this work, that we're going to see significant breakthroughs in the next year to 5 years, maybe longer or shorter, I should say, because of like we're just in this span, and we're kind of on this trajectory where we're coming around, I guess, to these massive, in technology with AI, with data collection, because it hasn't been done before. And the pioneers who started it 20, 30 years ago, now that stuff's starting to catch up.
Yeah, I completely believe that. I truly believe that. I think what will happen in cancer, I'll make some bold predictions, is for every cancer patient, one of four things will happen. Either we will prevent the cancer. So we're now beginning to understand that we can identify high risk. You mentioned BRCA.
Yeah.
We're discovering more and more genes that provide a propensity for cancer development. So we can begin to identify those individuals, and we're beginning to understand some preventative measures that can be incorporated into their lifestyle. It wouldn't, dramatically change their lives. That would prevent the cancer. So that's one. Two, we're developing early detection tools that will be able to detect an early cancer, and this is especially pertinent for pancreatic cancer, that can be easily removed or easily addressed and will never develop into advanced disease. Three, we will, for many patients, turn even advanced cancer into a chronic disease. And so if you look at even some cancers now, that were essentially death sentences just a short time ago. Certain forms of metastatic non-small cell lung cancer. And patients are living many, many years, decades even, well, a decade, let's say, where they're living with cancer. They're living relatively normal lives, and they have to begin to worry about getting their mammograms or their colonoscopies and watching their blood pressure, because the cancer is not going to kill them. They have to they have to worry about these more routine, let's say more mundane health issues. And then a group of patients, and hopefully this group, the last group of patients, begins to get bigger and bigger, and I believe it will, where we will cure a patient with advanced cancer. And I believe that to be true because I've seen it. This is not just a dream. This is not just imagination. This is the reality that's going on right now. I have patients. I still see patients in clinic once a week, and I have patients in my clinic who have no evidence of cancer, despite the fact that they had recurrent or metastatic disease. Were at one point, would have been given 6 to 12 months to live, and I'm seeing them 7 or 8 years later. And they have no cancer. They have no evidence of disease. And so this is happening. We need to make it happen in more than just, the unusual or occasional patient. We need to make it happen in the majority. But the fact that we can do it in 1 or 2 people, and it's much more than that, that means that we can figure out how to do it in a majority of people.
Yeah, it's
so that's
exciting.
That's where I see cancer. And in terms of the timeline, these things that I'm describing, they're going to happen in the next 5 years, certainly by the next 10 years. This is not, one day, 20 years down the road, 30 years down the road. This is going to happen in our lifetimes.
It's exciting. I love hearing about it and love talking about it. Let's shift gears here a little bit, Ezra, and talk about clinical trials and what you guys are doing at Tempus with the
Yeah.
clinical trials.
Yeah.
So
Yeah.
let's talk a
So,
little bit about that. Where do you want to
yeah.
start with
Yeah.
it?
So first, I'll say I'll make a plug for clinical trials. We will not do what I just described
Yeah.
if patients don't participate in clinical trials. And the sad reality, and this is, this is the genesis of the Tempest clinical trials mission. The sad reality of clinical trials in this country for adults is that 3% of adult cancer patients participate in clinical trials. We are just simply not going to make cancer go away if that number doesn't increase. Put it into perspective, all the advances that we made in pediatric cancers, especially pediatric blood cancers like leukemia, 90% of pediatric patients with ALL are cured today. That was only accomplished through clinical trials. That same 90% number, that's the percentage of pediatric patients that participate in clinical trials. So if we're going to move forward, we just need more patients to enroll. Okay, that's my plug for clinical trials in general. But that leads to why Tempus started a clinical trials program or a study, what we call it the studies business unit. And it was really with a recognition that that number was so low and that clinical trials had to change. The whole paradigm had to change. And so one of the first things that we did was we started what we call a just-in-time network, which basically means that instead of the paradigm of opening a clinical trial and waiting for a patient to become eligible, because we have connectivity with over 2,000 hospitals and oncology clinics in the country, we realized that we could actually go through the medical records, the electronic health record, and we could identify patients who are eligible for clinical trials. And then once we find an eligible patient, we can then open the study at that site. So it flips everything around. Is instead of waiting for people to show up, we know that they're there. We can open the study, and then the provider has a much simpler task of saying, "Hey, Mr. Jones, I've got a great study for you. Do you want to participate? And if you do, it takes me 5 to 10 days to open it." And
All
so
right.
that's the just-in-time network and sort of the cornerstone of the clinical trials at Tempus.
So I'm going to jump in here. I gotta, because this is like right on the tip of my tongue. So, and just preface this. So, yeah, you're right. Like, so it's usually like just set up the trial, wait for people to come. But if you guys can identify people and know that the clinical trial is available for them, they are eligible, and then go to that site and say, hey, we want to open the trial because of X, or you have this many people, or you have these many. Okay, I'm going to ask, there's no such thing as a stupid question, but then this is not going to be arrogant here.
Those are always the best.
Why wouldn't the powers to be in our country that run clinical trials, I think it's like NIH /clinical trials. Why wouldn't they say, hey, this is like a no-brainer? It benefits patients. Like, hey, Tempus, here's the entire universal database, or here's every partner that partners in clinicaltrials.gov. Go at it, have him.
Yeah, let me give you, I'll answer your question in a second, but let me give you one more nugget that makes this attractive. Is let's say you've got a community site in you're in Boston. So let's say what's the rough part of Boston? It's
well, there's
South Boston.
Yeah, I'd say Southie.
Okay, so sorry to South Boston. I'm sure it's not that rough, and I'll go visit next time I'm there. But let's say you've got a clinic in South Boston serving an underrepresented and underserved patient population. All of a sudden, those patients can have access to clinical trials instead of having to go to Dana-Farber or Mass General or one of the large academic medical centers that, quite honestly, they can't get to. They're going to have a hard time getting there, and it's intimidating for them to go there. So they can now go to the oncologist that they're seeing, their local oncologist, and that local oncologist all of a sudden has access to hundreds of studies for that patient that they would have never had access to. So it increases access to clinical trials, and it increases, most importantly, the diversity of the patients that we enroll in
Correct.
clinical trials, so that they now represent the true US population instead of the population that makes it to the large academic medical centers. So that's another benefit. So, but to answer your question, it's a few things. It's a few things. So first, in order for the system to work really well, or most efficiently, it not requires, but it's augmented by connectivity to the electronic medical record.
Correct.
We can do things, computers can do things a lot more efficiently than humans can. So that's one, and there's resistance to that. There's
Yeah.
resistance from a logistic perspective. There's fear about privacy and access and what we'll do with the data. And I can guarantee that we don't use the data for for profit or anything like that. We in this context, we use the data to try to put patients on clinical trials. But there's a fear around that. And then there's also, just like anything in medicine and any new technology, and I hate to say it, but medicine is a field of slow adaptation. Even though you'd think it would be different, but that's the reality. Institutions, the government, practitioners are slow to integrate new technology. And this is a new technology. This is a disruptive technology. It will happen. I have no doubt about it, because it's a better way to do it. But it will take time to get people on board.
I got so many of my own personal thoughts, Ezra, and you gave a very professional and very good explanation of why it's not happening. But I once had a very world-renowned clinician who's a bench scientist tell me something very intriguing, that, there's ego, and I think there's also, like, there's some institutions that, I mean, we fund a lot of institutions from around the world, not just here in the country, but that don't like to play with other people in the sandbox. But I think you said something that I caught: disruption. Like, this is what you guys you're disrupting the network, and no one likes disruption. No one likes change. We are founded on, and then this is not a plug on Project Purple, but like I started this thing because I wanted to disrupt the pancreatic cancer space, because nothing was happening, and I wanted to use running with that. So I love that. I mean, this is awesome that you guys are doing that. To me, it's a no-brainer. I mean, technology, I know you were very kind to say, like, technology might be an issue. Maybe that's for some people, but, like, I mean, this is 2024. Like, everything's done via the computer, via the phone. So, but to me, like, you bring up Boston, but I'm thinking of a patient right here in my head, a patient family that's in Davenport, Iowa, that, is going to Johns Hopkins, is going to Penn for clinical trials. Like, they don't need to do that. Like this is like game changer, man. And the thing that is so, and the other piece of this is, as you said, like, 3% of patients are in clinical trials, and that's a big problem why they fail. I think the space, and I think some of this is institutionally as well. And I'm not trying to put blame on, these large medical institutions, these places, but I think there's like a education piece to it. I've never met, though, a pancreatic cancer family or patient that's going through the journey that's never said no to a clinical trial. It's always like, A, I can't find them. Which one can I get into? Or B or C, they don't qualify anymore. But the reason they don't qualify, as you know, is they were never given the option up front.
Yeah.
Right.
Yeah.
It was never part of that roadmap wherever they started. But like, giving them this opportunity is so powerful, so powerful, and a complete game changer, as we know sometimes.
This is the reason the reason we started the effort is we truly believe that it has to be done differently. It's the only way we're going to make progress, and the only way we're going to make change. And you're absolutely right, Dino. It is rarely the patient that doesn't want to go on a clinical trial. I mean, if you present them with that option, they will, I mean, I would say 90% of the time they will, say yes to, of course, if it's an appropriate study, but
Correct.
and it should be, but it's the other barriers that we put in the way. And
Yeah.
I'll be frank, one of the barriers is that medical oncologists don't have time in a busy clinic. And so one of the things, that, and part of this effort is that we've tried to simplify the process. So we do a lot of work beforehand, the contracting, the approvals. We provide people on the ground to help with patient enrollment, first patient identification, enrollment, and then clinical trial management. We supply those people, and so we've realized that average medical oncologist in their practice doesn't have another hour to take out of their clinic and enroll a patient on a clinical trial. It's just, if you leave it at that, it's not going to happen. And
Right.
so let's break down those barriers so that we make it easy.
Yeah, but I agree and I disagree because I think some of these larger groups have someone on staff that can do that, right? Like it's
Yeah.
like, but it's just like any business or anyone. Like I think change is hard. I go back to, you said this and disruption. No one wants to be that disruptor, but at least for the GI cancer space that we're in for pancreatic cancer, this is what we need. Like you gotta, like I say this all the time, you gotta think outside the box. If we're really gonna make advancements or if we're really gonna push this and really gonna get better patient outcomes, I should say, not clients, but patient outcomes, we've got to kind of be a little bit disruptive. And we're not asking anyone to take anything that's not off brand. I mean, this is like such a value resource that potentially, it could be a huge game changer. And I know we brushed on this a little bit, but the immunotherapy piece is just such a frustrating piece here with pancreatic cancer.
Yeah.
But to your point, though, like we've got to put the work in. I think everyone always thinks like, hey, okay, this worked for this other disease, like it's going to work for us or this other cancer. But I don't think we've put enough work into it yet.
Yeah.
And I know that's really rude and crude at a very high level,
No,
but that's how I see things. I think we just have not put the work in immunotherapy yet to get it to where it needs to be for pancreatic cancer.
I completely agree. And pancreatic cancer, offers, again, as you and I'm sure many of your listeners know, challenges with respect to immunotherapy that other cancers don't have. Melanoma is sort of the prototype for immunotherapy.
Correct.
The response rates for anti-PD-1, anti-PD-L1 are 50%. You've got 50% survival even in metastatic disease. I mean, it's just, it's amazing. And then on the other end of the spectrum is pancreatic cancer with a relatively lower tumor mutational burden, a much lower tumor mutational burden, a very fibrotic tumor where T cells have difficulty penetrating, a highly immunosuppressive tumor microenvironment, and relatively few neoantigen targets. Having said all that, immunotherapy, I truly, truly believe, can still work in pancreatic cancer. So we've now got to the point, I think, with pancreatic cancer where we understand what the challenges are. And now we have to think about, okay, well, how do we knock down those hurdles one by one? There are a few neoantigens. Okay, well, let's identify the neoantigens that are relevant. There are ways that we can do that now. It's a dense tumor microenvironment that T cells can't penetrate. Okay, well, what do we need to do to overcome that? Is it cytotoxic chemotherapy? Is it small doses of radiation? Is it some other modality? Let's overcome that. Is it getting T cells right to the tumor? Okay, we have modalities that can help with that. Now, is it activating those T cells or reactivating those T cells? We have ways to do that. So at every step in the process, there are ways to do it. It gets back to, we need to put on people on, unfortunately, we need to test these in clinical trials. It's the only scientifically rigorous way we're going to get answers. And so we need to open up these studies. But I'll give you an example, and this is not immunotherapy, but a trial where we can see that these things, once we operationalize them, begin to work. We opened up a study in collaboration with GSK with a PARP inhibitor, thinking that patients with PAL-B2 mutation, so a much rarer mutation, a relatively rare mutation, they may be responsive to this class of agents called PARP inhibitors. And sure enough, because PARP inhibitors aren't approved for pancreatic cancer, we had a few pancreatic cancer patients enroll. And in fact, the only two that responded on the study were pancreatic adenocarcinoma patients, to the point where now we're talking to GSK about actually doing a pancreatic adenocarcinoma study with their agent, because we would have never discovered this signal if we didn't have all these things in place. So it can happen, and it will happen.
It's exciting. I've got a couple questions here left, and then we're going to share with our audience where they can learn more. My first question, and I know we've talked about all the great things you guys are doing there at Tempus AI. What if we've got a patient or a family member listening to this or watching this when this airs? Can they, let's say we'll use Miami, they're in Florida. Can they request to have sequencing by Tempus?
They can. It really it should and almost needs to go through their provider.
Okay.
So probably the best way to do it would be to talk to their provider, their medical oncologist, surgical oncologist, whoever that is, and they can order the test through Tempus. The nice thing about Tempus is that we have everything under one roof. So we can do the next generation sequencing, the whole transcriptome, the liquid biopsy, the germline genomics, the immunohistochemistries. So the provider doesn't have to go to different websites, different companies. It can all be done there, so nice and easy. And then Tempus does all the groundwork. We get the samples. We can even go to the patient's home and draw the blood. So we try to make it as easy as possible. So that would be the easiest way. The other way is the patient can go to the Tempus website, and I don't think they actually can't request it on their own, but they can get the information again to help their provider request it.
And knowledge is power. I always say, the great thing about this podcast, we never tell people what to do, but providing them access to the information. You guys have a great website, which we're going to share. And we're going to share some other links too, where they can find out more information. Is just so powerful. So they have that information.
Exactly. I couldn't agree with you more. The more we know, the better off we are.
Correct.
The better we are able to make the right decisions. If you don't have it, there's no way you can make the most informed decision. It's just no way.
Correct. And then I go back to maybe from your clinical days, it's really I think the system has become if you don't ask, you don't tell them things, right? And I always say to patients, here's the information, but you've got to ask the information, right? So here we are, hey, you guys are doing all these great things, but patient and their family still have to advocate for themselves.
Oh, absolutely. Couldn't agree with you more.
Second part of that question, and this again relates to the patient. So again, this clinical trials piece is just phenomenal. How do patients and their families get more information, or can they go to the website, or do they have to go through clinicians? It sounds like they could probably come direct, maybe.
They can certainly find out about what's going on at the website. We have a tab for research and appropriate pull down menus. So they can certainly find out on the Tempus website. What we have to do is we have to get clinics into our system, into the network.
Yeah.
And we're working on that, quite actively. We have an entire team that's all they do. They go to hospital systems, clinics, et cetera, and they try to encourage them to join our network. The network doesn't cost the system anything, zero cost to them, and we try to offer as many advantages and resources as possible. So we try to. I think it's quite attractive, but obviously they have to agree.
Is there a way then on the website that you guys list the clinical relationships that you have around the country?
There is a place on the website where that's listed. Yeah.
So if patients are in those geographical areas and
Yeah.
maybe that,
Yeah. We
by
cover.
automatically going, then
Yeah,
they would
we
know.
cover almost the entire country. There's the network now is over 300 uh, centers or clinics. We don't cover the mountain states that well. I'll
Yeah.
admit we're still trying to penetrate there. Fortunately, the population is relatively low there, but still we want
Yeah.
to be in those areas. But yeah, we're pretty well across the country.
Awesome. Awesome. Like I said before, like this is like to me a no-brainer. I know there's like, challenges in between there, with the way that we're doing clinical trials, has not worked. The system is broken.
Yeah.
And I don't think, we've talked often on the podcast about the systems, right? And I go back to what you said from being a disruptor. Um, I don't think you can ever change a system, but you can disrupt a system, right? And provide that service or what you guys are doing to change how we do this. And eventually the tide will turn, right?
Yeah.
And I think, again, I said this, knowledge is power. So by providing this to the patients, it's just a no-brainer. It's so powerful. Eventually what's going to happen is you're going to have patients like saying, okay, I'm not going to go to this center. I'm going to go to that center because I know they're affiliated with Tempus, and I know I'm going to have access, hopefully potentially, to all these clinical trials. So it's just really, really awesome work. I can't thank you enough, Ezra, for all the work that you're doing and all the great works that Tempus AI is doing to, not only GI cancer and pancreatic cancer in particular, because that's a space we live in, but all cancers as a whole. It's got to be really cool to go to work every day.
Oh, I love it. And the people I get to work with, a lot smarter than I am, let me tell you. It's such a pleasure. And it's really, and you feel like, honestly, there's a passion to the mission. We really feel like we're making a difference. And that's, there's nothing more satisfying than that.
So awesome. Well, it's been a pleasure to have you here on the podcast. Our last thing here, we'd love to share with our audience kind of the best place if they do want to learn more about Tempus AI. Where's the best place? I know we talked a little bit about that before we hit record, but why don't we give that to the audience here?
Yeah, it is the Tempus website. It's tempus.com. Just remember, it's not Tempest. It's spelled Tempus, Tempus, and either the website or on LinkedIn.
Awesome. Dr. Cohen, thank you for being a guest on the Project Purple podcast.
Okay, my pleasure again. Thanks very much.
Thank you for listening to another episode of the Project Purple podcast. If you like today's episode, please share this episode and follow the Project Purple podcast wherever you listen to podcasts. That's a wrap of another episode of the Project Purple podcast. Thanks for listening. Until next time, please be safe.